Welcome to the deep dive. We're here to really zero in on the crucial knowledge you need for your orthopedic practice, especially as you're prepping for those big postgraduate exams, the FRCS, fellowship exams, things like that. Today, we are tackling a really specific and sometimes, let's be honest, pretty complex area, peri-talar injuries. And our guide for this is going to be the fantastic Ortho Made Simple notes. You can find them over at mokyingren.sg. They were put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore, finished his FRCS back in 2022. These notes are just gold for cutting through the noise. So peri-talar injuries, maybe not the everyday case, but understanding them, absolutely critical. Their complexity, the potential long-term issues. Yeah, you need to know this stuff cold for exams. Let's dive in. Okay, let's start with subtalar dislocations. Could you maybe set the scene? What exactly is a subtalar dislocation, and how often do we actually see them?
Sure. So basically, a subtalar dislocation means you've got simultaneous dislocation of both the talonavicular joint and the talococcygeal joint. It's pretty rare overall, maybe about 1% of all dislocations. But here's the important bit for you as a resident. They often don't happen in isolation. You've really got to look for associated fractures, things like the fifth metatarsal, maybe the malleoli, or the calcaneus itself. Finding those tells you it was probably a higher energy injury.
Yeah, higher energy.
Yeah.
And classification, are the different types we need to know? Which one should really be on our radar?
Yeah, classification is, fundamental here. The one you'll see most often, we're talking maybe 65, even 80% of the time, is the medial subtalar dislocation. That usually comes from a nasty inversion injury, typically with some plantar flexion too. Then you've got lateral dislocations, less common, caused by reversion. And even rarer are the anterior and posterior types, the posterior ones, usually from extreme plantar flexion. But honestly, for exams, focus on that medial type. It's the most common, and frankly, it can throw up some unique challenges when you try to reduce it.
Okay, that's a great point. Challenges in reduction. What can actually block a closed reduction, particularly for those common medial ones? Because I hear it's not always the obvious things.
Exactly. This is like a classic exam question and a really important clinical point. A lot of people might jump to thinking it's the peroneal tendons getting in the way for a medial dislocation, but that's usually not it. The real culprits are more anatomical. Often the big issue is the tailhead itself kind of buttonholing like, pushing through the extensor digitorum brevis muscle, the EDB.
EDB.
Yeah.
Okay.
It basically just traps the talar head, makes closed reduction super difficult, sometimes impossible. Other things? Well, the talar head could get caught in the extensor retinaculum, or you might have talonavicular impaction, the bones just jamming together, or even, soft tissue bits getting stuck in there, like tibialis anterior tendon or joint capsule.
So knowing those specific blockers is key then.
Absolutely. It totally changes your game plan if closed reduction isn't working. You know what to look for if you have to go open.
Okay, so let's say you've diagnosed it, you're aware of these potential blocks. Walk us through the management steps. What's the systematic approach here? Any pitfalls?
Right. Systematic is the word. First thing, absolutely #1 priority. Check that neurovascular status thoroughly before you do anything else.
Crucial.
Totally. Once that's clear, you attempt your closed reduction.
Yeah.
The technique kind of depends on the type. For medial, you might accentuate the deformity a bit, pull traction, then reverse the mechanism. For lateral, traction and aversion.
And after the attempt?
Immediately recheck neurovascular status again. Whether you think you got it or not, always recheck. Now, if the first attempt fails, don't just keep reefing on it.
Okay.
A good next move can be putting in a calcaneal pin. That gives you much better, more controlled traction. Sometimes that's all you need to overcome muscle spasm or, minor soft tissue blockage.
Makes sense. And if that doesn't work?
Then you're moving to open reduction, no question. And your incision depends on the dislocation type. For medial dislocations, you'll likely use a lateral approach, lets you get right at that EDB muscle to release it.
And for lateral dislocation?
Medial approach, usually. Aiming to release the posterior tibialis tendon, if that's the issue.
Oh.
After reduction, big decision point. Is it stable? Feel it. If it feels unstable, pop in a temporary talonavicular K-wire.
Okay.
If it feels solid, then you just immobilize, usually a cast for about, say, 4 to 6 weeks. The big pitfall, rushing those NV checks or just trying closed reduction over and over without understanding why it's not working, that can just cause more damage.
That's super clear, thank you. What about the long run? What do we know about outcomes after these? Does the direction of the injury, like medial versus lateral, actually matter long term?
That's a good question. There's a well-known study, Jung Bluth et al. It was in JBJS back in 2010. They looked at a group of about 23 patients with just subtalar dislocations, no major bone fractures.
Oh.
They were all treated with reduction and then immobilized for 6 weeks. And the outcomes, Generally pretty good. But here's the really interesting part, especially for exams. They found no real difference in the long-term outcomes based on whether it was initially a medial or a lateral dislocation.
Huh. So the direction itself isn't the main predictor.
Seems not, according to that study.
Yeah.
It really underscores that getting a good, stable reduction is the key thing that drives the prognosis, more so than the initial injury mechanism itself. So focus on getting it reduced well.
Great insight. And just a reminder for everyone listening, these pearls are coming straight from the OrthoMade's Simple Notes, which you can find at mokyingren.sg. Highly recommend checking them out. Okay, let's shift gears now to something even more severe. A true dislocated talus. This sounds rare, but seriously bad news, right?
Oh, absolutely. A true talar dislocation is, yeah, exceedingly rare, way rarer than subtalar dislocations. And its presence, it screams high-energy trauma. Massive forces involved. And the absolute key takeaway for a resident is this. Unlike subtalar dislocations, where you try closed reductus first, a true dislocated talus always needs open reduction, period.
Always open. No exceptions.
Pretty much. Trying closed reduction is almost certainly futile and could even cause more harm. The anatomy is just too disrupted.
Got it. So when you go open, what's the surgical strategy? What approaches or techniques do residents need to have in their toolkit?
Well, the approach often depends on what you find. If there's already an open wound, well, that's your starting point. You'll extend it as needed and debride everything meticulously.
And if it's closed?
Then the direction of the dislocation usually guides you. For a medially dislocated talus, a dorsomedial approach often works well. If it's gone lateral, you're probably looking at an anterior approach. But you also need to be ready for some adjuncts. Sometimes just getting access is tough. You might need to use a tibiocalcaneal external fixator to distract the joint. Basically pull the tibia and calcaneus apart to make space.
Okay, distraction.
Yeah, it can really help. And in really difficult cases, you might even consider a malleolar osteotomy, cutting the malleolus, just to get the exposure you need to reduce the talus. Obviously, that adds complexity. You have to fix the osteotomy later.
Wow, okay. That paints a picture of how serious these are. Now, let's take it one step further to the extreme. An extruded talus. Like the bone is completely out of the body. That must be incredibly rare. What's the thinking here? What do you do?
You are right. Extruded talus, it's thankfully very, very rare, usually from, horrific trauma.
Huh.
And yeah, it presents an immediate major dilemma. Do you discard the talus or do you try to put it back in?
What's the current thinking on that? Discard versus reimplant?
It's a huge decision. Historically, maybe discarding was more common due to infection fears. But there's good evidence now, like a key paper by Smith and JBJS from 2006, showing that reimplantation can actually be safe and critically preserves much better foot biomechanics long term.
So reimplantation is often preferred now. How do you actually do that?
If you decide to reimplant, the protocol is strict. First, you have to debride the talus itself really well. Get rid of any dirt, contamination, non-viable tissue. Then you wash it thoroughly. The key here is using something like chlorhexidine, but, and this is important, non-alcohol-based chlorhexidine. Alcohol can damage the cartilage.
Non-alcohol wash. Got it.
Then you carefully reimplant it. But, and this is a huge but, you absolutely must counsel the patient extensively beforehand. Talk about the high risk of infection, the possibility it might fail, that they might need surgery later to remove the talus anyway, maybe even fusion down the line.
That communication piece sounds critical.
It's paramount. It's a limb salvage attempt, essentially, with significant potential downsides. The patient has to understand that.
Okay, moving away from dislocations now. The talus has some other specific fracture patterns that seem to pop up in exams quite a bit. Let's talk about the lateral process fracture, the snowboarder's fracture. What do we need to know?
Right, the lateral process fracture, important one to recognize. Anatomically, remember, this is where the ATFL, the anterior talofibular ligament, attaches. That gives you a hint about the mechanism, often dorsiflexion and avarition, common in snowboarding falls, hence the name.
And how is it classified?
You need to know the Hawkins classification for this one. Type 1 is basically a single large fragment. Type 2 is comminuted, broken into multiple pieces. And type 3 is really just a small chip, an avulsion fracture, the ETFL insertion.
Okay, type 1, 2, 3. How does that guide treatment?
The main factor is displacement. If it's non-displaced, let's say less than 2 millimeters gap, you can usually treat it conservatively in a cast. But if it's displaced, then you're typically looking at surgery. Either ORF, open reduction, and internal fixation to put the piece back accurately, or sometimes, especially if it's very small or badly comminuted, you might actually just excise the fragment. Goal is always a smooth joint surface and stable ankle.
Makes sense. Now let's swing around to the back, the posterior process. I find this area confusing because there are two different fractures back there with different names. Can you clarify that?
Yeah, definitely easy to get mixed up. So, posterior callus, you've got two main bony bumps or processes. The one on the medial side, its fracture is called Siddell's fracture. That's where the posterior part of the deltoid ligament attaches.
Siddell's fracture, posteromedial. Okay.
Then on the lateral side, you have the posterolateral process. A fracture there is called Shepherd's fracture. And that's the attachment point for the PTFL, the posterior talofibular ligament.
Shepherd's fracture, posterolateral. Got it.
And a key bit of anatomy to remember, running right between these two processes, is the tendon of the flexor hallucis longus, the FHL. Important if you ever need to operate back there.
FHL runs between them. And management for these Siddell's or Shepherd's fractures.
For the most part, they can often be treated non-operatively, especially if they're small, non-displaced, or the patient isn't having many symptoms. But if you've got a large displaced fragment, or if it's causing persistent pain or impingement symptoms, then OREF might be needed.
Okay. And finally, just briefly, talar body fractures. How do they stack up against, say, talar neck fractures?
Yeah, talar body fractures generally have a worse prognosis than talar neck fractures. That's a key takeaway, often because they involve more of the joint surface and have a higher risk of complications like AVN, avascular necrosis.
Worse prognosis. And how do you tell body from neck?
Anatomically, that lateral process we just talked about, that's kind of the landmark. Fractures posterior or through the main part of the talar dome are body fractures. Fractures anterior to it are neck fractures. Because of that higher risk of things like arthritis and osteonecrosis, body fractures often need really precise surgical fixation.
Okay, that covers a lot of ground on these specific fractures. So let's try and pull this all together. Thinking about residency, prepping for exams, what are the absolute must-know, high-yield takeaways from everything we've discussed about peri-talar injuries?
All right, the big picture. Number one, without a doubt, always do those immediate and repeat neurovascular checks. It's basic, but absolutely critical for any of these injuries. Don't ever skip it or rush it. Number two, really understand those specific anatomical blockers for subtalar dislocation reduction, especially that EDB muscle trapping the talar head medially.
Yeah.
Knowing why it might be irreducible is key.
Right, the EDB buttonhole.
Exactly. Third, the extruded talus. Know the protocol. Understand that reimplantation is a viable, often preferred option, but you must know the steps to debridement, the non-alcohol wash, and the crucial need for thorough patient counseling about the risks. And fourth, be solid on the classifications and management principles for the specific talar fractures we discussed, lateral process, snowboarders, and distinguishing between Siddell's and Shepherd's fractures on the posterior side. Know when to cast and when to fix. I think the common thread through all of this is just having a really systematic approach. These injuries might be rare, but they're complex. A logical step-by-step plan helps you manage them effectively, even under pressure.
That's a fantastic synthesis. Really focusing on that systematic approach, understanding the why behind the reduction blocks, and knowing the specific fracture patterns and their treatments. Thinking through these details, the surgical steps, the decision points, that's what makes the difference, not just for exams, but in practice. Well, we really hope this deep dive has helped clarify some of these complex peri-talar injuries for you, especially as you study. And remember, all this great info is drawn from the OrthoMade Simple Notes, which you can find over at mokyingren.sg.
Absolutely. And maybe just a final thought to leave you with. Thinking about how understanding the details of these really quite rare high-energy injuries might actually better prepare you for handling the unexpected, the really challenging cases that inevitably walk through the door, things that go beyond what any textbook or exam can fully prepare you for.
That's a great point to ponder. Thank you for joining us on the deep dive. As you continue on your path, pursuing knowledge and striving for excellence in your practice, we wish you guidance and strength. And remember the words from Proverbs 11:19. Whoever is steadfast in righteousness will live, but he who pursues evil will die. Go well.